Hello everyone. I'm going to describe a case for you for acute coronary syndrome. Let's begin. Okay, so we have a patient who's presenting to us with acute coronary syndrome. Their presentation would be they will have like a new or worsening chest pain. That would be retrosternal, could be squeezing or pressure pain. They would radiate to arm or jaw or neck. They can have shortness of breath. They will mention to you that it's worsening by exercise and gets better with rest and nitroglycerine. They could have like the vasovagal symptoms of nausea, vomiting, as well as syncopal episodes. In females, diabetic, and elderly patients, the presentation could be atypical with epigastric pain, back pain, burning, or stabbing pain as well. On physical examination, you will do a complete cardiovascular examination, including JVP as well as lung auscultation and looking for pedal edema as well. What are you going to find? On general appearance, your patient would be pale. You would find a new or a worsening murmur. Their vitals would show you hypotension, and on lung examination, you would be able to auscultate some craps. That would be secondary to the pulmonary edema. So, what will be your next steps? If this patient is presenting to you in a clinic, send them to emergency, get a serial ECG. If they are hypotensive, we have to make sure that it's not an inferior MI or a right ventricular MI. So you get a 15 lead ECGs for these patients, get a serial troponin, chest X-ray, CBC, INR, PTT, electrolytes, as well as magnesium levels, creatinine, urea, baseline glucose levels, baseline serum lipid levels. Very important to also get an echo before they get discharged. So our goal for stent placement or balloon inflammation is 90 minutes and goal for fibrinolysis is 30 minutes, so very crucial time. So on ECG, what are we looking for? So an ST elevation MI, we are looking for ST elevations of more than 1 millimeter into contagious leads, and in NSTEMI, troponin is positive. However, you won't find any EKG findings. You can find depressions. We will talk about NSTEMI in our next video. In unstable angina, they will have typical findings, but troponins as well as EKG would be negative. So here we see EKG, and we are seeing like ST elevations in V4, V5, V6, V2, V3, AVL, AVF, AVF, not really, but it's more likely an anterolateral myocardial infarction. So what is the treatment? Our treatment is to make sure our patient has intact airway, their breathing is not compromised. For circulation, you do IV lines, place them on oxygen and titrate it accordingly. Give them morphine if they have a lot of pain, aspirin, nitroglycerine. So you can give 0.4 milligrams of nitroglycerine every 5 minutes for a maximum of 3 doses, and usually you hold it if the systolic blood pressure is low. Anticoagulation, so if we are going for a primary PCI, we can do a unfractionated heparin. For thrombolysis, we can give a low molecular weight heparin. If we are planning for no reperfusion, then low molecular weight heparin. We also have to make sure we call cardiology so that a cath lab can be prepared and they can be taken for percutaneous intervention or thrombolytics. For long-term management, we have to educate our patient on risk factor modification, aspirin 81 milligram daily, and We can give them ticagrelor or prasugrel. This is after the consultation of cardiology. So, and also depends if they have a stent in place or not. Beta blockers for long-term management, and ACE inhibitors, um, as well as statin. So they all have a role to decrease the mortality. These are the complications of myocardial infarction. So there is a mnemonic crash pad for it. So cardiac rupture, arrhythmia, shock, hypertension, heart failure, pericarditis, pulmonary embolism, aneurysm, and DVT. Thank you. I hope this video benefits you. Thank you.